newly spread to southern parts of Australia from the top end. All right, so just remember that COVID is not the first, it's not the last pandemic that we're going to be facing with. And we get pandemics because there are large human populations, but more importantly, there's inequality. So there are a lot of people who really don't have access to good health care or information. And there's a lot of mixing, there's a lot of overcrowding, and there's a lot of movement. So humans are vulnerable to respiratory viruses, and that's permanent. It's here to stay. We need to think about how to respond to that. And it's not being helped by climate change and disasters. So, for example, we've just had a lot of flooding in the northwest and the Gulf country, a lot of people moving and mixing in ways that they didn't before, getting crowded into evacuation places, lots of opportunities for infections to spread. And that's one of the factors that can amplify outbreaks and pandemics. There's been some really good progress during COVID. One of them is that we can do Teams and not have to show up if we don't want to. But there's been enormous progress in rapid diagnosis, either the point of care tests or the PCR for COVID. And now we've got a multiplex PCR where you can test for multiple respiratory viruses at the same time with incredible accuracy. Really, really unprecedented compared to the old serology tests, etc. We've got a whole new generation of high-tech vaccines, not just the mRNA, but other ways of presenting the genetic material, including hijacking harmless viruses, viral vectors, and new ways of presenting stabilized protein antigens, that is, the antigen itself, not necessarily the RNA instructions for making it. Really amazing progress and getting these things done really quickly. And again, within a very short time, because of all the stuff we know about molecular shapes and structures, we were able to produce monoclonal antibodies and antiviral drugs against COVID in unprecedented time. So this is really exciting in terms of the battle with pandemics. Now, just to remind ourselves of the standard strategy that we would use again if we had another pandemic respiratory virus. Early on, restrict movement, including international travel, all of that stuff around social distancing, hygiene, hand sanitation, and then isolation and quarantine. Isolation is for people who've got the disease and might be infectious. And quarantine is a waiting period for people who might get the disease. With all of the attendant gripes about the damage to economy and personal rights that have to be balanced. Immunisation is about coverage. That's the game we're playing here. And I think one of the things that we're worried about is in the hangover from all the misinformation and nonsense around COVID vaccines, it's damaged our other vaccination campaigns, and coverage in all parts of the world has dropped, particularly here in the school-based immunisation program, for example, not so much among babies. We're not sure what it's doing to flu either, but we really need to get back on the horse. Hey, this is saving lives. This is frontline business for all of us. In terms of that coverage, of course, there were mandates because we had an excellent and safe vaccine, in fact, several of them, for people who could put other vulnerable people in risk to have the vaccine. That's you and me, isn't it? Because we're dealing with very vulnerable and sick people. Now, once you get to a point where enough people have got some degree of protection, in this case, immunisation or vaccination, that's when they started to lift the restrictions and allow the virus to spread through the population. But it wasn't open slather as they did in China. Can anyone tell me what the problem with the Big Bang opening up, let her rip kind of approach was? Yep, go ahead. Yeah, you smash the health services. People die from other diseases because they can't get a bed. And so that was a very considered process. There was a lot of debate, but the basic idea was correct, wasn't it? Let's let it spread, but not all at once, and still keep those social and hygiene restrictions in place so that we can get through this together. All right. And meanwhile, we're maintaining a high degree of surveillance and research. Surveillance means finding out how much is out there. And I'll talk more about some of the surveillance problems as we go in. And we know that the research has shown us that, as with many outbreaks, it's not just one wave. It comes, it goes, it comes again. And there are various reasons for that, including getting into different segments of the population, different age groups or different social groups. And also because these buggers keep changing, don't they? And so you will get strains that evolve to be resistant to or relatively resistant to people's current set of antibodies, and even to the antibodies elicited by the vaccines. And so it's a sort of an arms race going on. And we've seen various waves, depending on where you were in Australia, and even now, smaller waves and a large number of variants circulating all at once. All right. And also, of course, the surveillance is about the safety and efficacy of treatments and vaccines. And we put enormous effort into following up important adverse events, and we rely on you guys to report them. Yep, the big ones, they all come across my desk, and our team are really keen in ensuring that the vaccines are safe. And when those things are reported, they go straight through to the large computers in Canberra, where they are looking to see if there's a signal. Is encephalitis, for example, happening more often than you would expect in association with this vaccine, or is it just the same as the background rate? And we've been able to show in the past, for example, that measles vaccine did not cause autism because the rate in those who are vaccinated is identical to the rate in those unvaccinated. And of course, nowadays we know that there are genetic causes, and you can detect autism well before any of those vaccines are given. So it's kind of ended that argument. All right. As I say, nowadays we are looking at, can we keep up with all of the variants? Is that a question online, or is it just a microphone? Okay. And I'll talk about what's happening with the evolution of the vaccine in that arms race. And basically, all of the problems around recovery of health services. I think the lesson that we've been learning is that recovery of the health services is not simply getting back to normal. There are a lot of people who are damaged, exhausted, left the profession. There are huge backlogs in all sorts of healthcare and health-seeking behaviour. And there's been a hangover in disease and death, much more than expected, after the main waves of COVID. Some of that seems to be virus-related, and some of it seems to be the damage to the health system and the community. Really interesting stuff. Okay, so they are the waves that happened in last year. And since then, they've only been relatively small waves, but there's a problem with the data. It looks like the waves are going down every time, doesn't it? Oh, we're going to be over this pretty soon. There's a problem there. Can anyone tell me what it is, why we may not be getting the same information now as we used to? Yep. Yeah, most people don't report their COVID. Yeah. That was the other thing I wanted to say. I hope there are some pharmacists in the room. Are you one of them?
Yeah.
Welcome. It's great to see you. All right. Yeah, and so it's actually getting harder and harder with these point of care tests, and people not even testing, not wanting to report. And so it becomes a lot harder to follow the data. All right, so this approach of, I don't like to say COVID normal. COVID is not normal. It's a horrible killer disease. Yeah. But what they're trying to say here is that we can't afford now to silo this disease from the other respiratory diseases. We need to start thinking about them together, because the presentations, and I always say, what did your mother say to you when you were a kid? Yeah. She said, wash your bloody hands. Don't cough on other people. Was there your mother like that? Yeah. don't go to school if you're sick, you're going to hurt the other kids. She might not have mentioned the masks and the distancing. Yeah, but we have reverted to the hard lessons that were learned 100 years ago. Yeah, those things are absolutely important and we need to keep doing them, particularly in our workplaces. And I know that our GP practices have done enormous things around improving ventilation and distancing and masking up and protecting our customers and our staff, including the way that we organise waiting rooms. There's a whole thing about when is the rat test a good idea and when would it be better to do the multiplex PCR, polymerase chain reaction, which detects the actual RNA of the virus, whereas the rapid antigen test is trying to detect the protein of the virus and it's not particularly accurate. So the rough rule at the moment is if you're outside of a hospital environment, then probably the rapidity of a rat test gives it a big advantage. Yeah, you need to know quickly because you need to know what to do with people and what to tell them. In a hospital environment, probably the reliability kicks in and you can get the PCR test done really quickly and do some more costly and difficult things around infection control. So what they're saying now is really we're promoting rat testing outside the hospital and PCR testing inside with a number of exceptions that you could guess. Yeah, when it's important, when it doesn't stack up and you think it might be an error with the rat test, etc. All right. Now, the other thing that is going to remain is that some of our most important diseases, including flu and COVID, are notifiable. That means that the labs should tell us, doctors should tell us, and we want the population to tell us through the web portal. Although we can't enforce that, knowing about them helps us, and particularly in vulnerable settings like aged care facilities, even childcare, cruise ships, prisons. They're the sorts of environments where we might have to do more. We investigate, we get more aggressive around isolation and infection control and trying to stop it overwhelming the facility. Nobody wants to see 7 people at once die in a nursing home, even though eventually the virus is probably going to reach everybody, including people in aged care. And it is still killing quite a lot of elderly people. And unfortunately, if they're up to date with the vaccines and we're offering antivirals, there's not much more we can offer. There's really not much more we can do, and at least they're not losing too many years of life. All right, we are getting smarter about having more options to make it easy for people to vaccinate. Yeah, that's why I'm 100% in support of qualified pharmacists with or without nurses vaccinating. Yeah, it's not rocket science. It's not that hard. And the public health team is here to help. And there's always been pretty strict supervision of cold chain, etc. So we're trying to make it easier for the community to get those vaccines in, which I think is great. The other thing that's changed is that we are a lot cleverer these days about pregnancy. When I was a student, my God, don't give anything to a pregnant woman because they had some really nasty drugs that damaged unborn babies. But now we've got really good data and evidence to guide us. And we know that vaccines like flu and pertussis actually protect the newborn as well as the mother. Yeah, and we know that COVID vaccine is safe in pregnancy. And so there's now vaccines which not only are safe in pregnancy, but they're a really good idea. We'll come back to that. We're making more progress with the mRNA vaccines. Respiratory syncytial virus, which is a big killer of children, in the US, they are shortly going to license, it seems, a vaccine product that protects elderly people, and it's probably a matter of time before we've got protection from one of the last really nasty respiratory killers of children. So I'm looking forward to that. There will be new waves of COVID. This is going to go on for a long time. Basically, what happened is a new virus appeared, which children generally get through really easily and then have some immunity for life. Our misfortune was that this thing came along while we were adults, or we were vulnerable and elderly, and that's why quite a lot of people died. And I'll talk about the estimates in a second. We think most Australians have had a basic course of COVID vaccine, and we think that most Australians have had COVID. Some of them had such a mild illness they don't even know it. Some of them didn't get tested. What we've learned is that your primary course of 2 doses of any of the COVID vaccines is good, but a booster is much better, even 1 booster. So that's the old 3rd dose. And then after that, you've got reasonably good protection. However, just remember there's quite a large number of people who never had COVID vaccines or boosters and are still at higher risk of disease or death, severe disease or death, and particularly in our remote Indigenous communities, where it was only about 2/3 ever had a primary course, and even less than that a booster. Right, so, and that's because mainly about access. I don't know what you guys have got to say about that, but we really didn't supply it in the same way that we did to mainstream communities in the suburbs. The other big point is that we know that once you've had an infection and survived, you've actually got really strong immunity, particularly if you've had the vaccine and the disease. It's called hybrid immunity. It means that you've got the benefit of the vaccine and now you've had a disease. You're very much less likely now to get severe disease or die. Right. The other thing that we've learned, and that's a really strong and long-lasting immunity, but the boosters are working a bit differently to what they were originally. We're finding that the boosters are not lasting particularly long, roughly about 6 months, and the protection is not absolute. It means it probably isn't doing much to stop you getting COVID, or even to stop you from spreading it, but it will definitely make a difference to your risk of hospitalisation and death. So COVID boosters now are about hospitalisation and death. They're not necessarily preventing disease. They certainly probably have an influence on long COVID, but they're not as good as they used to be, which is ironic, isn't it? And that's because the virus keeps changing. Yeah. The most recent data we have suggests that if you're over 65, it is definitely worth getting another booster, whether it's number 4 or 5, I don't mind, so long as it's 6 months after your last infection with COVID or your last booster. I'm 61. I'm going to go and get it. I'm going to have the new bivalent one because it's probably very slightly better than the original one, only a little bit better. But remember, this could change. If there was a very different variant out there, it might change the whole equation. So if you're a young person and fit, you don't have a lot of risk factors, you can be quite relaxed now if you've been vaccinated and had COVID. Whether or not to get the vaccine, you probably have to weigh that up against the chance of side effects. We do know that occasionally people get anaphylaxis. We do know that rarely people get pericarditis or myocarditis, particularly relatively young males. And so you would have to then balance that up against the benefit of COVID boosters. But right now, if you're over 65, absolutely, the equation is very much in terms of improved chances of survival or not having to go to hospital. The other thing we've learned, of course, is that you can give COVID and flu vaccines on the same day on the basis that a bird in the hand is worth 2 in the bush. They may not come back, and they're far better off getting the 2 vaccines at the same time, even though, of course, the more vaccines you give at once, then you're adding up the probabilities that they'll have side effects, and then they won't know which one of them caused the minor adverse reaction. But Absolutely. If you need to give both at once, do that. Flu and COVID are still reportable to air. Okay, that's compulsory. That's the Australian Immunisation Register. Let's just remind ourselves about flu viruses. Whenever you see a picture of a respiratory virus, it's got these little things sticking out all around it. I used to tell people, well, that's why they call it coronavirus, but you can see that flu virus looks almost the same. What are these little lumps on the outside of the bit of membrane that surrounds the respiratory virus? They're basically the tools for hanging on and getting in, aren't they? Yep. And a virus is like a little machine. It's inactive. It's just a bag of genetic material. But if it hooks in and gets into your cell, it forces the cell to make more virus, usually kills the cell. You can't treat viruses with antibiotics. That's why sometimes it's important to make the diagnosis, and that's where rapid tests can be very helpful. So different types of flu. Flu A often causes pandemics and epidemics, and flu B is usually at a smaller scale and probably doesn't cause a huge pandemic type illness because they don't change as much. Flu viruses are animal viruses. They're mainly in birds. Sometimes they jump into other mammals such as swine or whatever. But the spikes on a flu virus are called hemagglutinin, the H, and neuraminidase, the N. And again, they're just about getting in, multiplying, and then getting out of the host cell. The problem is that flu is a mutation engine. It shuffles different H's and different N's, and it can come up with a completely new variant that your immune system doesn't know or may not remember for the last 40 years because that type wasn't circulating. And sometimes you get the strange thing where people younger than 40 have never seen it before and they get really sick. The people older than 40 have got some memory, some immune memory from when they got it as a kid. And so you can have this thing where young people get worse than old people. Very interesting. I wanted to make another comment about COVID is just a flu, or flu is just a mild virus. Both are wrong. If you had three categories, you'd say all of the mild viruses like cold viruses, metapneumovirus, parainfluenza, and in adults, certainly RSV. And then you've got flu. Flu is a nasty disease. It kills officially about 1,000 Australians per year, probably unofficially about 3,000 a year. Now, during 3 years of pandemic, COVID killed officially 13,000 Australians until last September, so it's probably more than that. But unofficially, probably 5 to 10 times as many. And the way you do the unofficial is that you look at projections from additional mortality from the periods where you didn't have the virus. Remember, COVID can provoke a heart attack or increase your cardiovascular mortality. Yeah. So a lot of people, COVID was a contributor to underlying causes of death. And so it could have been 50,000, well above what you normally get from flu, and flu is well above what you get from the common cold. So don't tell me that flu and COVID are just flu. In fact, I call it real influenza because people use the word flu very loosely, don't they? And COVID, hopefully eventually will be one of the mild viruses, but our whole generation is experiencing it the first time as adults, and that's why it's nasty. This is 1919. The biggest flu pandemic killed more people than the First World War. Yeah, millions, maybe 20 million people. And they didn't have much that they could give them then. They didn't have a vaccine and they didn't have antivirals. So we are very careful about flu, and every year, because flu happens mainly in winter, we watch the Northern Hemisphere to see what happened in their winter, And they watch us to see what happened in our winter to try and predict what strains are travelling around. If they get it wrong, the vaccine won't work. Fortunately, this year, we haven't had to change the vaccine from 2022 very much. And it's mainly H3N2, which we've had for a few years now. And flu is hopefully returning to the usual seasonal pattern. Last year's outbreak was actually quite early, but it wasn't severe. And we're not sure what's going to happen now. One of the Bs that we put in our quadrivalent vaccine seems to have disappeared, but it's too late to pull it out. If we knew that, we would have put 3 As and 1 B. Instead, we've got 2 As and 2 Bs because we didn't know which B was going to circulate. We're expecting a good match to the vaccine this year. Efficacy more than 50%. Now that sounds pretty crappy, doesn't it? What's the efficacy of a COVID vaccine like Pfizer or Moderna? Anyone know? Have a guess. More than 60? Yeah, over 80. 85% typically in the studies. So why are we using a vaccine that is so unimpressive? Anybody?
Patients have already been exposed to influenza of some type.
Right, you're on the right track. Yes, the very smart person in the audience has just told me that a very large percentage of the population will get it and had it. And because it causes a large degree of morbidity and mortality, 50% is actually very, very useful. Yeah, you said that, didn't you? Yeah, I'm sure. So yeah, even 50% for a flu vaccine is good, although it's nowhere near what we got for COVID. Flu vaccines don't last forever. Remember, they're killed vaccines. And so the first 3 or 4 months, you get really strong protection. It starts to fall off after that. And there are certain groups where you might even consider vaccinating them twice if it's a long season. Come back to that. The problem with the winter flu outbreak thing is that it doesn't happen in the tropics. Here in North Queensland, you can get flu at any time of year. And the bad news is it's already started. And so never mind about what they say down south in Sydney and Melbourne. If you get that flu vaccine in your hands early April, start using it. Yeah, don't muck around. I wish it was here this month. So there you are. They shuffle. This year we've got the H3 and the N2. We didn't know that, but we guessed. So we're looking pretty confident that we've got this thing nailed this year. This is, if you can see the dates and the numbers, you can see that the annual flu outbreaks from 2017 to 2022, the 2022 happened earlier than the other outbreaks. If you look, the other funny thing about that slide is that I can see 4 lines, but I'm describing 6 years. Where are the missing lines? Is this just bad graphing from me? Flu disappeared during COVID. In fact, all of that hygiene and travel restrictions and mask wearing worked better for flu than it did for COVID. We almost wiped flu out. And now, of course, it's come back, and it will stay back unless we were to have another pandemic where we took severe restrictions. It's actually along the baseline there, those different colours along the baseline. That's the pandemic years before 22. Interesting, eh? Okay, so these are the strains that are in the 23 vaccine, very similar to last year and very similar to the Northern Hemisphere. As I say, we missed out with the B Yamagata. That's gone, apparently. And if we had our time again, we'd probably put some other A strain. Never mind that they say Darwin or Sydney. That's just the people to first describe it. It's not like we invented that strain here. And that will be the same whether or not these are viruses grown in traditional eggs or in cell cultures. Nowadays, some of the vaccines are made in cell cultures. Remember, they're dead vaccines. Now, this complicated table, which we've got as a handout, Kath, is that right? Yeah. Is all of the vaccines that are available on the Australian market, including those that are provided by the National Immunisation Program for free. The flu ad is the one for over 65s. It works better than the standard vaccine because it's got an adjuvant. An adjuvant is basically something that provokes the local immune system. It says, hang on a minute, what's this? There's something funny here. And it aggravates the immune response. The high dose flu vaccine is private market, but that will also work nicely for over 65s. And then, as you can see, some of the other age groups, Fluad, you could, Blue Cell Vax is the cell private vaccine, but you can't give that to under 2 years of our age. And there's one or two that you can't give to under 5s, Afluria Quad, but all of them that you could give to most of the other age groups. But we prefer the adjuvanted vaccine for over 65. If you don't have it, then give them something. And the stars there represent people where it's funded by the National Immunisation Program for Indigenous people and people with medical risks, which is a really good idea. This is the simplified version of the vaccines that we're making available through the state. And again, get the table and label the vaccines in the fridge so that you don't mess it up and give the wrong dose. And then you've got to ring up one of the Cathys or Sarah or whatever and say, what do I do now? Well, too late, you've done it. Now, when these errors have occurred, we haven't had any different side effects, but that's what the evidence is telling us is appropriate. They haven't done the trials or slightly different doses, although the volume is the same, 0.5 ml. You know, one of the things we've been trying to do for years now is to remind people that flu vaccines are also for children. Yeah, children, the first few times they get flu in their life, it can be a severe disease. They can get very nasty complications, and we're always getting people admitted to hospital who are young with flu. Not only that, young children are filthy. They've got really dirty habits and the snot and the sticky fingers all over. They spread the flu, yeah? And one study, you could reduce transmission of flu in the community by 60% just by keeping these dirty little things vaccinated. So remember that. If you give the first year that they get a flu vaccine, if they're under 9, you should give a second dose a month later because, again, it's like a primary course, whereas you and I have been battling with flu for years. It doesn't conflict with the other vaccines. I don't think there's any specific restriction on it. It's a dead vaccine, by the way, so it's quite okay if you give it with the other vaccines on the schedule, the dead vaccines. And then, of course, I'm not going to read that to you, but there's a whole list of medical conditions where you can get a free flu vaccine because, frankly, the Premier doesn't want them taking up hospital beds. Yeah, they've got high risk of getting flu, and so no matter what age they are, it's really important to help those people. If you're not sure, give us a call. Yeah, the only thing that I don't see on there is obesity and smoking, but a lot of them will be caught up in basically the medical complications of those factors. The other thing that is great about these vaccines is that you now don't have to send away half of the Indigenous family. You could give the whole lot the flu vaccine because they're at higher risk in poorer communities. So this is a really big advance. A whole lot of them, anyone over 6 months, jab them all at once and they're all done. Now, again, correct me if I'm wrong, but I understand that they've already started sending out, well, they will be sending it out in about a week. And by after Easter, everybody should have their first delivery of flu vaccines. Don't wait, don't muck around, get that vaccine into people. Call them in if necessary, and you can reorder from the 11th of April. All right, we're in a hurry to get this going. It would be tragic if somebody died because there was some delay in getting the flu vaccine out there. We know this thing is already spreading, particularly in North Queensland. Fridge labels, separate them out, make sure that it's idiot-proof in terms of who gets which product. Remember again, this, when people are there for the flu, think about pneumococcal. Yeah, and one of the great things recently is the far more powerful conjugate Prevnar 13 vaccine is available for many groups and age groups. Basically, anyone over 70 in the mainstream and over 50 in Indigenous communities, or again, a whole long list of medical indications. And for all of these groups that also qualify for Prevnar, give the the Pneumovax, the old polysaccharide vaccine, give that after the Prevnar. Yep. It's usually 2 months, Kath. Thanks for that. Yeah. I'll just make a very quick comment here about Gardasil. The research is in. This is probably the most successful vaccine I've ever seen. It's incredibly safe, very powerful, and beautifully prevents those viruses that cause cervical, oral, rectal cancers, throat cancers, and now a number of other warts as well. So much so that they've now decided that you get very good protection after even a single dose. Now that we're vaccinating boys and girls, we're getting herd immunity. In other words, the virus has got nowhere to go in the Australian population. And they've bumped up the catch-up period to 25. Because these viruses are not circulating as much, you've got a longer period to protect everybody. So use that, particularly because we're still getting problems in our school vaccination program. A lot of these young men and young women will come to you when they're of age and say, hang on, I actually do want this vaccine, because they know the truth. Number one factor in people's vaccination decisions, and all of the research shows you, is the recommendation of the health professional, the doctor or the nurse. Nowadays, the pharmacist too, I'm sure. Yep. That's what makes the difference. People trust us for some reason. Beyond that, they talk to their friends and their relatives, and they go on Facebook, and by then you've probably lost the battle. And there's some really fantastic stuff. I've just been looking at the NCIRS, the National Centre for Immunisation Research, and yeah, and they will talk to you about the way to talk to people about their doubts or their hesitancy, how to listen carefully to what they're saying, how to not get confrontational, and just help people to direct them to useful information, or maybe come back to them another time. And you'd be amazed at how successful you will be in persuading people about vaccine. All right, this is a picture. I've shown this a few times before. Flu in pregnancy, it kills pregnant women and their babies. It's a well-known thing. Every year we get a few people in intensive care. This lady was 3 weeks on ECMO. That's when they have to put you on artificial oxygenation through your leg arteries. 6 weeks in ICU and lost the baby anyway. She survived. Yep. Flu kills pregnant women and their babies. Get that flu vaccine to anyone who's pregnant. And if she gets pregnant after you've given a flu vaccine, give her another one in the same season if the flu is still circulating. This is one of those people, including some people with immune problems, where you would do that. Other vaccines for all pregnant women, is diphtheria, tetanus, and pertussis. And we know that pertussis kills babies, and we know that if the mother is immunised, it reduces the rate of pertussis in the baby. Yeah. We can do this now because we've got long shelf lives in modern vaccines. That flu vaccine will last right through the season until it's no longer circulating. If it is circulating, keep using it. And as I say, we need to make sure that all obstetric and antenatal services include it. And it's about the providers. If you suggest it, many people will take it. A question up the back?
Second flu vaccine, how long after the first one?
Oh, that's a good question. So that if you had to give the flu vaccine twice, what would be the separation between them? Look, I'm guessing, and I stand to be corrected, but normally we would give it about a month. And that means that you've had your reaction and you build up your antibody to the vaccine, and then the other one is going to act as a booster. So that's what I would do, but it's not hard and fast, and we're not experiencing a problem in that area, but it's a really good question. Okay, I'm going to move away from vaccines unless there are any burning questions about some of that for now. I want to update you on some other diseases. Diphtheria. You know, diphtheria used to kill 20% or so of all children. More than 100 years ago, it was one of the big killers. Diphtheria. It's a bacterial throat or skin infection that if it carries a poison called diphtheria toxin, it will kill the lining of your throat and you will choke to death. It's horrible. And for many years now, D has been included in childhood and even adult vaccines. Yep, in Hexa, in DTP, in DTPA. It's got all the Ds in there for a very good reason. And we've been quite disturbed that we're seeing cases of diphtheria. So diphtheria germs haven't gone away. They're still spread around and cause throat and skin infections, but normally it doesn't contain the toxin. But we've had a number of outbreaks in Palm Island and the Torres Cape Indigenous communities. We're terrified it's going to get through the Gulf country into the Northern Territory. And it's no accident that this is happening mainly to poor and overcrowded communities. It's not the fact that you're Aboriginal. It also happens in migrants and refugees around the world who are kept in very unsanitary conditions. If you haven't been immunised for diphtheria, you could get that horrible toxin effect, not only killing your throat, but affecting your nervous system or your heart or other organs. And so we worry about this. And right now, there's a toxigenic strain circulating. And that means that you need the vaccine to protect you as well. There's a question. Great question. The question about adults or children. Problem with diphtheria vaccination is that it doesn't last your whole life and it starts to wane. So because nearly every Australian has had their basic infant vaccines, we're seeing it in older teenagers and young adults. And that's probably because they haven't had a vaccine dose or a booster since they were a baby. And so the reminder today is people with minor wounds, everybody who's pregnant, people from these communities where there's been a problem, absolutely, it's important to give those diphtheria tetanus boosters with or without the pertussis component. So that's a sign of waning immunity if you push the average age of infection up. It's not the babies anymore, it's slightly older. Great question.
Child presentation.
Yeah, I'll come to that. Question about the presentation. And it's in the next slides. So yeah. So we actually trace them and the contacts to see if we can find other people at risk in the household. This is a human germ, spreads person to person. And a lot of work on opportunistic boosters. Catherine was out on Palm helping the team out there with a campaign just last week. So there's the germ. It's a gram-positive rod. It looks like a dumbbells that you use in the gym. So it doesn't come from the environment. It comes from other people. So ordinarily, it's just skin and throat infections. The labs often dismiss these as normal flora, but right now, in some of these places, we're asking the labs to characterise the diphtheria-like germs to see if it really is Corynebacterium diphtheriae, and if detected, we're sending it for toxin testing. Not all strains make the toxin. And there's another one called ulcerans, which occasionally makes toxin, and that's from animals. So we've done that. So you can't just say diphtheria. This is a bit complicated. There's the bacteria, there's the toxin, but the definition of the disease is bacteria plus toxin, even if the person is immune and they don't get sick. Or down the bottom there, what it says is, if you've got the bacteria that produces the toxin and you're not immune, you are in trouble. Yeah, but if you're immunized, or it's the one that doesn't have the toxin in it, don't worry, and we're not even calling that diphtheria. And we've spoken about the fact that you can get diseases and outbreaks, and non-immune persons or people with waning immunity are the main risk. So one way of saying this is, look, there are venomous and non-venomous snakes. They can both bite you. They can both make you sick. But with the one with the venom is what we've been immunising against. We haven't stopped these snakes from going around. We've just made some people resistant to the venom. Now, but I think that important question was, what does it look like? What is the presentation of the disease? So some of the strains have the tox gene, and we test actually for the genetic material because nearly always that material is producing toxin. It takes a few more days after the lab has detected Corynebacterium diphtheriae, and it causes local necrosis. That thing in the throat, it used to be called a pseudomembrane. It's not a membrane, it's dead tissue. You try and pull that off, all you do is cause catastrophic bleeding. Sometimes the whole throat has died and the person is in deep trouble in intensive care. Now, sometimes the skin disease looks like ordinary infected sores, but sometimes they're very clear, deep, punched out, nasty looking ulcers as well. And then if you're getting the toxin effects, a few weeks down the track, you might be getting heart block or rhythm problems or nervous system problems, generally peripheral neuropathy. All right, so we've had about 35 cases. 8 of them were clinical and respiratory. Most of them were indigenous, and the rest were mild toxigenic cases of the skin, where we didn't need to admit them to hospital or give them antitoxin, which is made by horses, and you've got to use it really quickly. We've got antitoxin at Cairns and Townsville Hospital now. There's the skin punched out lesions that you can get. If you're suspicious, ring public health and we'll talk about what to do. If they're sick, look in the throat and swab the throat, and we will help you with contact tracing if we get a toxigenic strain, but that'll take a few days down the track. Cover the wound, wear a mask. This thing is infectious, so we need to protect ourselves as well. Normally the close contacts are not health workers because they're taking precautions. And the close contacts, we would often vaccinate and give antibiotics. So they're the numbers of cases we've had. On palm, it's not huge, but it is a concern. We don't want someone dying from this disease. If you get a respiratory diphtheria, like with that membrane in the throat, it's a clinical emergency. You've got to get them to hospital for airway support, and you've got to get antitoxin into the very quickly if you're using it. You've got a bit of time for antibiotics and contact tracing, and then follow-up vaccination. So remember, diphtheria is part of the whole deal, and this is what, that's an American poster, but it's very similar to what we do here in Australia in terms of the primary baby vaccines and then the boosters, including every pregnancy for adults. Any questions about diphtheria? All right, moving on quickly. Yep. Great question. Why isn't ADT3? In a way it is. It's in the doctor's bag supplies you can get from the Commonwealth. Unfortunately, Boosterix or Adacel that contain the pertussis, the acellular pertussis, is a high-tech, expensive vaccine, and so it's not funded for that purpose. But we've been using it for outbreak response through the state. But it is free for every pregnancy and at those maintained boosters. But as you know, for tetanus, ideally every person would be getting a dose every 10 years, and not all of that is funded. Thank you for that. Okay, I want to change the subject and talk about melioidosis. Now, this character is having great fun with his mates, cleaning up after the heavy wet season and the floods in Townsville or somewhere else. The trouble is, he's old. He might have diabetes. Some of these characters are getting around with bare feet. They're getting scratches. And there's a bacteria in North Queensland called Burkholderia pseudomallei, which is one of the causes of severe wound infections and then sepsis or pneumonia and death. In fact, if you get melioidosis, you've got a very good chance of dying. Even in our hospital here, about 10%. And mainly that's because it tends to affect elderly and debilitated people. So I'd rather he wasn't mucking around in the mud and the dirty water. He should be making the sandwiches, frankly, and let the young people do the job because they're pretty resistant. They've got strong immune systems. So mud is common. Melioidosis is not. The media love to talk about it, but it's not the most common thing you get from cleaning up in the mud. It's ordinary staph and strep infections and wound infections and all sorts of other things. It could cause acute and overwhelming sepsis, but also just abscesses and skin ulcers. Often it's in the prostate or the genitourinary system. And as I say, a high death rate. Simple stuff like wearing shoes, covering wounds, not breathing this stuff in, the sort of precautions that all of us should be using if we have to work in the mud, but really try and get young people to do it. The other funny thing about melioidosis is that it's a bit like TB. You can get internal abscesses that go quiet for many years. And the famous thing is that the bloke has come back from Malaya or Vietnam, and then 30 years later, the melioidosis reactivates. And meanwhile, he's caught it somewhere else. We can't vaccinate for melioidosis. And look at this, what's happened in recent years. It's almost doubled in a couple of years in Townsville and in North Queensland as a whole. We don't really know the reason why. I can guess. I'm going to give you some guesses. Right. Well, there's an increasing population of elderly and debilitated and non-immune people who don't have people at home to help them do the gardening. Yeah. There's more and more roadworks and building and construction that is disturbing the soil. This is a soil germ and it comes up with the water table and with the heavy rain onto the surface. We are a bit better at diagnosing it, but these floods, again, is a sign of climate change. And this is leading to more often where people are confronted with unsanitary mud and all the rest of it. There's a picture of the germ on a gram stain. Famously, it's got a little clear blob in the middle. They look like safety pins. And generally, they have an intensive treatment phase in the hospital with IV high-tech antibiotics and then several months of Bactrim to try and stop it from relapsing. We don't really know all the reasons why this thing has increased so much in North Queensland. I've spoken about all of that. Wear gloves, boots, long sleeves if you must, and be very careful about wounds and scratches, particularly if you're diabetic or you've got something wrong with your immune system or if you're heavily into alcohol. Right, I've only got a couple of minutes, but I wanted to mention viral encephalitis coming from mosquitoes. You might have heard of all the fuss about Japanese encephalitis. This is normally seen in Southeast Asia and has hardly ever been seen in Australia, only at the top of Cape York and in the Torres Strait. And this wet season, it got all the way down to South Australia and Victoria. This is, so Kunjun, Murray Valley, and now Japanese encephalitis are all flaviviruses. They're actually distant relatives of dengue and Zika, but they're spread by ordinary bush mosquitoes, and there are billions of them. You will never get rid of those mosquitoes. So basically these mosquitoes spread it among water birds, herons and egrets in the top end. That's where they live, including the Gulf country. And then in a heavy wet season, when all the rivers are flowing and Lake Eyre is filling up, that's when they can move down vast distances into the rest of the country. And those viruses will accidentally get into other animals, the horses, pigs, and humans. Now and then somebody will get very sick. Unfortunately, this new one, JE, Japanese encephalitis, it gets into pigs in very high numbers and it's called an amplifying infection and it infects the mosquitoes. So there you are. It used to be a travel vaccine. It still is. And for example, if you were going for months in the wet season to rural areas, you would think about this vaccination. If you get the full-on encephalitis from Kunjun, Murray Valley or JE, a third will die, a third will be damaged, and a third will get better. The good news is that only about 1 in 1,000 people who are infected by the virus get encephalitis. Most of us will just have a very mild illness or nothing at all, and then you'll have antibody. Interestingly, in these areas, it's usually people who are not the locals in the top end who get sick because they may already have experienced these viruses. It's visitors and it's children. And so transmission cycle, again, very similar for these three viruses. Kunjun is particularly good at killing horses. The other name for it is West Nile. And so we've had occasional outbreaks in the Torres Strait. I don't know why we're doubling up on our pictures there. That's really weird. And there have been deaths. So there was a vaccination campaign in the outer Torres Strait Islands for when this came down from PNG, either in birds or mosquitoes. So just a reminder of the JE vaccines. JSPECT is a cell culture inactivated vaccine, but you've got to give it twice. There's a newer vaccine, a live attenuated. Remember, the live vaccines you can't give to pregnant women or people who are immunosuppressed or under 9 months, but it works better and lasts longer. And right now we're vaccinating people who work near pigs all over the east coast of Australia because we're worried about Japanese encephalitis. We hope it will go away again in a dry season, back to the top end or back to PNG, but we don't know. So right now we're not worried about household mosquitoes, we're worried about bush mosquitoes. And Japanese encephalitis is actually very similar to Murray Valley and Kunjun. It's children and visitors that we worry about more than the locals because they might have already had a mild infection. I'm going to stop there and check if there are any questions. I'm sorry, I've gone a bit over time. Yep. Oh, maybe if I can just go online, can I ask the people online, you be very quiet and polite? Any of you got a question, just turn on your microphone and give a yell. No. All right. The lady in the room, sorry, yes. Yep. Pig workers, pig hunters, in fact, whole districts, including the Northwest district, the Gulf country in Mount Isa. They said anybody who wants it can have it. So the government is offering the vaccine, but the uptake has been low. And that's similar to what's happened with monkeypox. And let's be frank, also with COVID. It's one thing for the government to say, oh, the vaccine's available for free. But if you don't promote it and nobody knows, then it's pretty hard, isn't it? So yeah, all sorts of categories, including health workers and environmental health workers and anyone who works with pigs. Probably you should have it if you're pig hunting. But it's not like you're going to get it directly from the pig. It would have to be mosquitoes that are biting pigs that have had the disease. Yeah. Any other questions? Yep.
It's on Friday to have second run.
Right. Yeah. So the question is about who and how long you should give a second flu needle. That is the exception. Most people, and the funding is only for 1 dose. But a new pregnancy would be one of the reasons. People who are immunosuppressed, and normally you would get specialist advice on that. And really the interval is not that important, even if it's as short as 1 month. But yeah, I'm just saying that it's possible. But use this vaccine right away, and for as long as flu is circulating, it will save lives. It's really important to do that. And don't forget COVID vaccine boosters as well, particularly for the elderly. That's by far the biggest risk factor. Okay, folks, I want to thank you all. It's really great to see you in person and to meet our friends and colleagues, and particularly welcome to pharmacists who are now doing a great job with more vaccines. I'm very pleased to hear about that. Thank you online, everybody, as well. If you haven't signed in, folks, the people in the room, you can do that with Kathleen. And thanks to our IT support.
Yes. Yeah, which one?